something up that is very topical. So you guys have come along. You've attended what we call a basic skills colonoscopy course. So you've been looking at how you've been handling a scope. One of the things that we do with a scope is that we actually aim to do therapies, so there's no point in actually doing procedures. So what I'm going to do, I'm going to talk about an advanced procedure in colonoscopy, but we'll be focusing on more of the basic skills with regards to what you're doing before we would actually still show you how we would go about taking off this large polyp. The big thing about colonoscopy is that you need to take your time to look at areas. So today, in particular, we were looking at an area of inflammation, we were looking at slight engorgement areas, all these type of things. So you have to be aware of what you can see. Everybody aware of what this is? So feel free to talk. Does this thing point?
I think there's one on the...
So, what is this? So I'm going to actually be very pointed. I'm going to say, what is this? Polyp. So what type of polyp? Pedunculated. Right? What do we look at before we actually... We've got this polyp. Would you consider taking it off? Yes? What would you do? Take biopsy. So how are you going to do the polypectomy? What you're saying is, why is the patient on your table in the first place if you don't already know those results? Okay? What he's saying is he knows those results and he's now assessing the polyp. What he's saying is he's looking at the stalk. How can you do this? You can put a forceps out, you can move this across, you can move this across, you can go past it, you can come back, you can look and see how it's actually adhered to the base. Does it look takeable? Okay. Is anybody aware of a polyp assessment tool that enables you to understand how this polyp would be safe to take off? To give it a classification, because you guys like to work towards classifications. Is there a classification that you can use that will actually enable you to understand how safe or unsafe this polyp is to take off? No. No. Paris classification helps you understand whether it's disrupted or not disrupted. Is it depressed? That then tells you about the likelihood of how successful you will be about removing the polyp. I'm on about a tool you can use. Right. So what is this assessment tool called? Are you aware of any assessment tool? Dimensions? Anything else? He knows the answers, and I'm going to say be quiet in the front. He's getting there, man. So, access, dimensions. He's already access. He's already said dimensions to me is size. So I understand what he's saying. Oh man, let these guys come up with it. Yeah. I bet he was terrible in school. Yeah? Also, is it 1P, 1S, 2A? That helps you understand? Is that Paris classification, 1S, 2A? No. So what classification is that? So you've got Kudo? Yeah, yeah. And so what other ones have you got? So you've got Kudo, we've got Paris, we've got Nice, we've got JNet. Any others? There's loads of them. Lots. So the ones that I tend to stick to, I like the JNet, and that is going type 1, type 2, type 2A, type 3. Type 3, leave alone. Type 2A, might be successful. Type 2, you will be successful. Type 1, you can do something with as well. So you've said size, morphology. You said accessibility. Anything else? Nope. He's implied that by saying stalk. What makes it, where is it safer to take off a polyp? It's still not safe to take off a polyp. Where is it least safe to take off a polyp? Where have you got a bigger chance of putting a hole in someone's bowel and a less chance of putting a hole in someone's bowel? Go a bit further. Go a bit further. Go a bit further. Go a bit further. Right. So what have we actually done? What have you actually named as you've gone along the colon? Different sites. So, SMSA, has anyone ever heard of it? Size, morphology, site, accessibility. So size, for example, less than 10 millimetre, you get 1 point. 10 millimetre to 30 millimetre, you get 2 points. Did you notice I turned my hand? And then 30 millimetre and above, you get 3 points. Right? So that's size. Morphology. Depending on the morphology, depends. So if it's pedunculated, it may be 1 point. But it could be on size 3 points. So that gives you a total so far of 4. You see where we're going with it? So semi-pedunculated, 2 points. And sessile, maybe with a 3, maybe 4 points. So that's how you go along with your points. So size, morphology, site. So rectum, maybe 1 point. Well, it is 1 point. Cecum, it's getting riskier. That's 3. Okay? So that's about your accessibility and site. Accessibility is the fold. That comes back to your morphology. Depth is where it's depressed. That's your morphology. How deep you assume the lesion is going. So how you, if it's a sessile lesion, you would lift and you would see it lift, and does it actually crown and lift? The endoscopic ultrasound is very novice in this area and there's no role for it at the present moment in time.
I mean, unless people who are specialized in doing ESDs, they would use it. But generally speaking, the main thing is what Paul and I follow is when we inject under the polyp and if it's a lift, that's your indication that you can take it out. If it doesn't lift, then don't touch it.
Then don't touch it. You could lift the edges, but the centre then and that forget it. That's something. Then you could consider ESD, but ESD you still might not get complete clearance. You could go back in 6 months, biopsy the site, and still come back with normal mucosa, but you could have malignant tissue underneath that is just hiding there. And that's what you've got to be mindful of. So if you can't guarantee clearance, don't bother doing it. The big thing about doing any polyps, have you got the skill set to take this polyp off? So how many of you would be worried about this polyp? Would you take this polyp? You would? Okay. I'm going to tell you this polyp is 3 centimetres. It's over 1 fold. Okay? So already we're looking at accessibility. It's over 1 fold. 3 centimetres. Have you got a big enough snare? So we're looking at 7 points already. It was in the sigmoid, so it was 1 point. The scoring system aligns itself against someone's skill set. So in the UK, any of you guys coming across this polyp, if any of you guys attempted this, I would be inviting you to my office to discuss. And that's because this polyp is actually trickier than what you think. Because size, morphology. What do you do when you look at morphology? What are you looking for?
Basically the stalk.
What about the stalk?
If it is bigger, the more chances of bleed.
Mm-hmm. Is that it?
So it would be difficult to remove.
Okay.
Bigger the stalk and the vascularity would be high. So
What else tells you the vascularity is high?
the shape of the body would also be an indication of
I mean, he's MBI. If I was to tell you this, that stalk is there, comes here. And when I went to take this polyp off, I looked at the polyp, and the stalk went like this. Pulsating. How many of you would actually take time to watch the stalk? So now you know it's pulsating. What are you going to do? How? Endoloop has a lot of complications. Endoloop is actually, when it goes in, it actually shapes like a boat, like a leaf. And when it comes in, this tail sticks up and it gets in the way. Injection? What do you inject? Where? Why? Okay, if I was to say to you, stick the adrenaline in the head, what do you think that's going to do? Instead of the base, stick it in the head. Polyp reduction. If you put the injection into the stalk, and then you take the polyp off and it doesn't bleed, are you happy? You're saying no. Why are you not happy? It's not bleeding. You've injected into the stalk, you took the polyp off, and it's not bleeding. Are you happy? What do you do? Anything? How soon after? If you inject a stalk that is pulsatile like this with a substantial amount of adrenaline, this will start to bleed significantly between 4 to 6 hours later. Significantly. Okay? So what did I do? Applied clips. Can you see now the size of the stalk? That's not a clip, that's the stalk edge going off that direction. So the stalk actually is a lot bigger than what you think. These clips are 13 millimeter mouth open. This one is only grabbing at that point, and this one is grabbing the back point. So what we're talking here is a polyp with a stalk of 30 millimeter in diameter. This thing was doing this.
Is there any size cutoff value that we consider bigger stalks and pre-treated?
If you've got a large stalk, there is a chance that there is a large vessel within it.
Large stalk is defined how much millimeter? Is there any cutoff value?
Right, so now you're asking, do I work to, this is 10 millimeter, do I worry? Yes. This is 5 millimeter, do I worry? Yes. This is 20 millimeter, do I worry? Yes. Regardless of the size of the stalk, you have to examine the stalk to see what it's doing and how it reacts. And the big thing is that people want to be saying, if it's less than 10 millimeter, what do I do? If it's less than this, what do I do? That is something that you want to stick to as a guideline. I don't give guidelines, I don't give protocols. What I'm saying is that you look at what you've got. So if I was to turn around to you and say, you've got a polyp that is 1 millimeter to 5 millimeter, what do you normally take that off with? You've got a polyp of 1 millimeter to 5 millimeter, what can you remove that with? I didn't say pedunculated. I said a polyp, 1 millimeter to 5 millimeter, what do you take that off with? You can take it off with forceps. You can take it off cold. Okay? If you've got a polyp of 6 millimeter to 10 millimeter, what do you take it off with? So you can look at cold snare. Now, which one is likely to have greater malignance potential? What is the actual risk of there having a significant change in that, not necessarily malignancy, but an adenomatous component? So, what is the risk to the patient of that polyp that you've taken off that is 6 to 10 millimeter, that will have an adenoma component of all polyps removed? What is the percentage chance? So again, if you don't know, why are you doing it? So it's 1 to 2%. In the group that is 1 to 5 millimeter, it is actually very, very rare that they will have an adenomatous component. However, having said that now we can have these areas where we've got serrated adenomas, etc. We should actually be looking and considering, do we have to remove all polyps? Well, you should do. But when you actually have got areas of a lot of metaplasia, you actually start thinking, I'm not going to spend half a day here removing all these. So you can have these golden rules where you say 1 to 5 millimeter I'm going to do this, 6 to 10 millimeter I'm going to do this, thereafter I'm going to do this. You have to play each polyp by what its presentation is. You still have to have 2 millimeter clearance. So if you're going to remove something with forceps, what size polyp can you remove en bloc with forceps? What size polyp can you remove en bloc with forceps? Bet you never thought of this. Sorry? Never say about. Tell me, what is the largest size polyp you can take off with a pair of standard forceps? En bloc. Right, so what I'm actually trying to get you to do is think about the head size of the forceps. Forceps, and we've seen you guys use the forceps on this course. Now, if you were to look at forceps themselves, are you aware that the forceps, when it's open, the jaws are as sharp as a razor blade? Are you aware of that? Well, if you're aware of that, why did the most of you put the forceps out open and then slide them along the mucosa? Would you get a razor blade or a scalpel and slide that along the mucosa? So why do you do it with the forceps? So you say you are aware of these things, but then you actually don't pay the equipment the respect it deserves. So forceps themselves, they are very dangerous instruments, but they're also a great tool. Forceps don't just take biopsies. You can touch the mucosa. If the forceps buckles, it tells you it's very firm. If the area bleeds, it tells you that there's contact bleeding. Once you close the forceps, once you pull them back, if the mucosa tense, it tells you there's no inflammation or swelling. Taking a biopsy tells you a lot more, but having them open and sliding them along the mucosa, you might as well get a scalpel and do the same thing. In answer to the question, the forceps mouth is 2.5 millimetre to 3 millimetre. So that's the largest polyp that you will be able to remove en bloc. So if you've got a 5 millimetre polyp, you actually have to take it with 2 bites, even 3 bites, because you'll normally grab it in the middle and you'll be left with 2 residual areas either side. So we pre-clipped. Can you see here? What's happened here? Ischemia. We took it off. No bleeding. Now, if you'd have just injected this, no bleeding, you'd probably leave it. But I've already said to you, this is a 30 millimetre stalk. This is going to bleed. I know guys, senior guys, and Vakar will tell you, the senior guys who will take this off without actually doing anything before. Because if it bleeds, then they'll treat it. However, you can send the actual blood supply that's going in into spasm, and it doesn't bleed. Now, you can take off a polyp, and have you often seen that ragged area left in the centre in the mucosa? And as you've taken off that polyp, and how many of you have gone off to that ragged area and then tried to actually treat that ragged area in the middle? You'll have seen a lot of people do it. What you're actually trying to treat is a blood vessel. So when you take these polyps off cold and you see this little ragged area in the middle, it's actually the blood vessel that you've left behind. And you then going at it again and again and again is just actually you're trying to treat a vessel and remove a vessel. And you've actually sent it into spasm. So this is the reason for this talk. There is a standardized recommendation that you should have for your settings. So if we look, polypectomy, coag, forced, snare resection. Set the power at 15 to 30 watts. Now these machines, when you press the pedal, if you set it at 15 or 25, not this machine, but if you set it at this wattage, right, it will deliver this wattage. This is an Irby machine. What's the difference on an Irby machine? Do you know? I set this at 25. If I see anybody set it at 280, I'll be if you were in England, I'd be calling the GMC and reporting you. But here, you set it at 25. What this machine does, which is quite intelligent, it measures the amount of resistance at the point of delivery. So as soon as you press the pedal, it measures the amount of impedance in the tissue. So should the snare be too tight, it will deliver less. Should it be too loose, it will deliver more power. This 25 is what it will deliver up to. It won't necessarily deliver the 25. Soon as you press the pedal, it measures the level of impedance, and it will deliver 25 watts at maximum. And if the snare is too tight, you'll then cold snare it. If the snare is too loose, you could actually potentiate a perforation secondary to diathermy. The standard system where you set it at 15 to 30 watts, it's often better to set it at the lowest setting and then use the actual speed that you close the snare to actually take the polyp off. Polypectomy, forced coag, precondition with endocut. So this is the endocut. Do you use this system here? Has any of you used this system? I know Vakar will have done. This is the desired unit in the UK. What this is actually saying is yellow pedal. Can you see what it says? Endocut. Cut. It's a brilliant with the RCP. When you press the pedal here, the blue pedal, what does the blue pedal normally mean? When you press a blue pedal, what does it mean? Coag. And that's true. Do we know what the wave of a coag current looks like? So why are you pressing the pedal? The wave of a coag current is uniform, consistent, with round edges. A cut is sharp, comes up, comes down, comes up, comes down. The longer you press the pedal, the more of those waves you deliver. The higher the coagulation, the higher the peaks, the lower the troughs. The same for the coag. On this system, you've also got here, which is called effect. Now, effect is actually talking about how dense that current is. So should you have effect 1, you will have a number of these waves. If you have effect 4, they are longer and less waves, less cycles. So you actually deliver a greater area of coagulation in effect 4. So if you're going to use it, you'd use effect 4 in the rectum. You would not use that by any stretch of the imagination in the cecum, because you'd end up having cause necrosis and perforation. You have to be aware of it, because if there is an effect setting on your diathermy, that's what it does. So it's like using a hose pipe, and you have the hose pipe on 2 litres per minute, and you have it on jet. That shoots forward. You still have it on 2 litres per minute, and then you adjust the hose pipe to be on spray. So it's less force behind it. So more force is 1, less force is there, but there's a greater area affected. Understand your coag, because if you don't, you shouldn't be pressing your pedal. Understand your equipment, because if you don't, you shouldn't be pressing the pedal. And also be aware that the person doing the closing of the snare, they can actually cause you a complication if they don't do exactly what you're asking. And when you actually assess a snare, have the snare opened, closed, and then open slowly so it just appears, and then mark the proximal part of the handle which is going away. That then gives you an idea of how much stalk is actually in, or polyp is in the snare itself. Okay? There are different types of equipment. Can you see this here? Needle knife. Any of you guys using it? Again, I'd invite you to the office, because this is not appropriate. Injector needles. 21 gauge, 23 gauge, 25 gauge. Do we know what we're talking about? So what we're looking at is the narrower the needle, when we inject the solution underneath, leaves a small hole. Should you then use gelifusing or saline, it will seep out of that area that you've done. So should you use a needle that you would use for injecting potentially a varix or an ulcer, that's the wrong size. You should be using a smaller needle. However, in Pakistan, you're going to use what you can get. So if you are using the larger one, leave the needle in, get the snare ready, get them to remove the needle, take it out, new one in it, the snare in as quickly as possible to reduce the amount of leakage that's coming out. Spray cannula. Different shapes of snares. I like the round snares. I don't like these snares, because when they open up, they always hit a fold and they come down. Barb snares, they actually can grab tissue. They can cause you more problems than what you think, because as they close, they can grab tissue behind you. And these things are just a gimmick. Okay? If you don't know how to use them, don't use them. But the bigger the snare, the bigger the problem. With a small snare, you'll make a small hole. Any hole is a hole too far. You shouldn't be making them. Forceps, alligator, clips. Now, rot net. Because you reuse things, this doesn't apply to you. But in the UK, you get a rot net or similar out. What you should do is open the rot net, if it's brand new, dip it into water. That activates a sticky coating that's actually on the net. As soon as you put it onto the actual polyp, it sticks to it, and then you can close and it'll safely remove. A lot of these nets come along. Can you see this has got a nice little cup? but there are some that look like tennis rackets and they're very stiff, and you're forever trying to do things. The rot net has a very stiff plastic sheath. This stiff plastic sheath can actually go through a bowel wall very easily. So I actually get the staff to open the rot net in the scope, and I then deliver it over the polyp. If I'm working with a new member of staff, I'll pass the plastic of the snare out, draw it back into the scope, brand new member of staff, ask them to open the snare in the scope. I'll then slide the snare out and guide the actual thing over myself. Because when you ask this member of staff to open the snare slowly, the snare is open. When you ask them to close the snare slowly, the polyp is off. So when you actually ask them to do something, I say, I'm going to ask you to slowly close the snare, and I want it closed at this rate. So be very prescriptive. These help. These, you just lose the material. I'm not going to go into too much detail because this is not appropriate for your level at this time. So, an audit of 20 millimetre polyps in 2000, 142 lesion analysts. So what we were looking at is the size of polyps taken off in that time. Tattooing, 46 to 77%. Now, the area of most common missed lesions, where do we miss lesions most? I mentioned this on day one. Bends? Okay. Where do we miss lesions most? I mentioned it on day one. Cecum and rectum. We go in with the scope and we miss the lesion because we're not really looking. We negotiated, we're so happy to get to the cecum, we start to come back. We don't look, we don't pause, we don't take time. We get all the way back, we're fatigued, and we take the scope out. We don't look in the rectum. Most common places of missed cancers, rectum and cecum. You get there, great. What did I say on day one? Now the test begins. The test isn't about getting there. That's about the skills that you've been trying to acquire while you're here. The skill then starts in that you actually look at where you're at. Okay? If you can actually take that tube out and say that I have actually given this person the best quality observation I could do, and I would have actually done the same thing for my mother, my father, my brother, my sister, my wife, my children, then I'm happy. But if you can't, then what the hell were you doing? And that's what you've got to ask yourself. What this is going on about is that lesions, large lesions, it's often best to actually tattoo. Because, as I've mentioned to you before, recurrence is quite high in these large polyps because people's techniques are not that good. Significant disparity between groups. So 46% and 77%. The 46% cecum, 77% rectum. You've left the cecum intact. Now, when you actually tattoo, if you can take a picture, great. If you can't take a picture, not so great. But what you need to do is describe. So I never tattoo the base of a polyp. Why do I not tattoo? I tattoo the opposite wall, directly opposite. But why do I not tattoo the base of a polyp? No. Some people use the mix. I'm not a fan of the mix. There's a lot of studies that have gone off. You know the mix where they talk about using gelafusing, putting indiacarmine in, and then putting adrenaline in. Now, you need to go and look and see what the recent studies have shown, which have showed that there is areas of necrosis secondary to the mix itself. And I actually put that down to the adrenaline. It's something I've been saying for the last 15 years. I've never used the mix. I refuse to use it because I actually have been one of the people saying that the adrenaline actually causes ischemia. You have damaged that mucosa, especially in the cecum. You've taken at least 1 millimetre into the wall. It's leaving approximately 1 millimetre of tissue left. Should you have then injected that area with adrenaline and some have gone into that area, you can cause ischemia and there's a potential for delayed perforation. So there is issues about it that I was never happy with, so I didn't use. Yes, it allows you to delineate between the polyp base and the actual polyp tissue that comes off. And I can't argue about the quality of the image when it actually sits there and looks lovely and blue. But the big thing is, and I demonstrate this on here, I don't use it in my normal practice. But what you have to do is understand where it has benefit, where it doesn't have benefit. So don't just use something because everybody's using it. Use it because it's the right thing for the job at the time.
If they're not using the mixed thing, they're just using the Indian currency, then we can take
Right, India coming into the base is wrong again because you actually got carbon within the actual Indian ink. Carbon has been shown to show localized irritation, and the agitates that it actually causes. Yeah. So Indian ink, when it's actually injected, causes irritation. That again causes inflammation. That again can actually lead to issues in the actual mucosa. I do not inject in inflammatory bowel disease for a start with Indian ink because I do believe that it actually causes issues with regards to mucosa. I won't do it. So if I see an area that I'm not happy with, I will actually be very descriptive of where it is. So there's a polyp. 3 folds distal to the IC valve. As you look at the IC valve at 8 o'clock, the polyp is positioned at. Be prescriptive, be descriptive. That's where it is. I have now gone into the rectum. Valve of Houston, 3rd one, adjacent to, at the 6 o'clock position. All right, so very prescriptive. Put some.
Another important thing about tattooing is that, as Paul rightly described, it's a very pro-inflammatory agent. I mean, technically, the reason tattoos are because it's taken up by the market projects are histocides and it stays there forever. The important thing is if it goes intraperitoneally, it causes a very intense peritonitis. So when you are injecting it, as we all do, we start off with injecting normal saline first, this way. With a blood there, leave the needle in there and change the syringes and change over to India ink and follow it up with a flush with it. Because if you inject straight in and inadvertently it goes deeper into the perforate, it causes a very intense reaction and covers the whole peritoneum surface with India ink. So it messes up everything.
So your injector needle, how much does it hold? How much does your injector needle hold?
The dead space.
What is the dead space of an injector needle? So you prime it with, how much does it hold? How much does it take to prime a needle? So I've always asked you not to guess.
Best thing is always, because the needle may vary, so always do it in front of your eyes.
So it is, the majority is 1 millimeter, 1 mil, right? So what happens is that you will actually flush with 1 mil of saline. You will then start your injection. As it goes in, you raise the bleb, stop. You then inject 2 mils of the tattoo, if you wish. But what I tend to do, and then you actually then flush with 1 mil of saline behind. That then makes sure that you've delivered 2 mils of tattoo ink and you're leaving in the actual needle just saline again to go to a different site. That's how you can do it, and you have to be aware of what your equipment does. So in 2011 we saw those results. This is 4 bowel cancer screening. These guys, as I've said to you, I suppose there's 327 who've been assessed throughout the UK. Primary surgery, 18, these are all the different when they've actually come off and had their initial endoscopy and failed polypectomy. Can you see the significant numbers of gone on for further surgery? So in the most expert hands, we're showing how doing EMRs and polypectomy is not effective, even in the supposed most expert hands. These are solutions that you can use. I'm not going to go into it too deeply. But what all I'm going to say to you is be aware that there are various liquids out there that have products in that can actually cause compromisation with some people's significant religious values. there's a randomized control trial that was done, and on this they show the size using hyaluronic acid. They show the size and efficacy of actually doing the polypectomy and have an assurance of what the size, morphology, location, etc. And they split it down to age using saline versus hyaluronic acid. And you can see down here experience of the endoscopist. We're looking at morphology. They don't go on for your classifications, 1PS, 1S, 2S, all this type of stuff. Endoscopic experience, they're looking at how the person is good. Complete resections. See, even in the expert hands, complete resection is not even guaranteed. That's 1 in 5. The biggest thing that you need to do when you're actually going to take off a polyp of any size is what? Nice watch. Is spend time looking at it. It's easy and straightforward to take off a polyp, and it's, if you disrespect the polyp and the mucosa around it will disrespect you. If you don't take your time, and I showed you that 1p polyp back there, you didn't know on first glance that was a 3 centimetre diameter stalk. On first glance it looked very straightforward, but that was a 30 millimetre stalk, only because it took time. That 1p polyp, I said to you guys, how many of you would take that polyp off? You all went, yes. How long did it take you to go, yes? I said, how many of you would take that off? Yes. That's how quick you were. If I turned to you and I said, I looked at that polyp, and 11 minutes later, I decided that I was going to take it off. If you guys had said, well, it looks takeable, but I'd want to know this, 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 and this. So I have a criteria. Now, this is now working towards what I'm saying to you, to yourselves, and you want something to work to. So, look at the stalk. That's what connects it to the actual bowel wall. Look at its mobility. Look at its accessibility. Look at the colour of it. Look at the disrupted pattern. Should I not be successful? Should I actually hit it and it starts to bleed? How can I control it? If I take it off, am I going to have access to actually stop it bleeding? I've seen guys take a polyp, draw it back, take it off, and couldn't get back to where it was bleeding because they took it on a distal part of the bowel. Patient had to go for surgery. I've seen that demonstrated on a very eminent study day where somebody said, all right, we've got this polyp. I can't get to it, but very straightforward. The polyp has been put under tension. Tension is not just by closing the snare. Tension is by how the snare is actually pulled back, how much air is in, and the bowel is pulling against it. So you can't sometimes see these things. So assessing it, having good views. And I've also seen people take off polyps and they've grabbed mucosa behind. Move your snare. The big thing about delivering diathermy to the previous polyp, which we haven't touched on, what is that polyp doing? Right. So when we put the snare here, where does the electric current flow through? It flows here and it flows there. So some people move it. I tend to move it ever so slightly. That's to stop one point of contact here, not here. Okay. So you're looking to see where it's exiting. Polyp came back, by the way, as cancer. Endoscopically completely excised with a 2.3 millimetre excision margin. So, happy. What happens, what do you do when you do take off this polyp? Even though I'd got these clips in place, one thing you don't see, only because of the picture, I did remove it, I didn't take it out, I just pulled it back into the scope, is the snare. I leave the snare there. I watch it for the next minute, 2 minutes. Should it show signs of bleeding, I open the snare, drop it over, and I tamponade it. I don't close it too tight, I just tamponade it. Wait, and then stare at it. Chat. How's the weather? And then I think, what should I do next? Is it another clip? Is it an injection? So it gives you time to think. So all these things you do in managing. So if you've not got access to actually stop the complication, then should you be doing it in the first place again? So these are things you've got to actually think about when you're taking off polyps. And if I'm brutally honest about my own practice, the only times I've had issues is when it's been with the diminutive small polyps.
Paul, can I just make a point here? Because I mean, people might think they're all like clips endo loops should be done in hand, which people who know what they're doing. Because the problem one can encounter with putting clips on, unless the is very good, is that your snare might touch the clip and cause extensive burns in the mucosa. So it's always don't put clips on if you are not trained how to do polypectomy or top of clip. Secondly, with endo loops, like Paul mentioned earlier also, do it only if you are your staff is good at doing it. Because in our department, what we tend to do is every 6 months we have a dummy training for the staff because these things are not frequently done, and even your nursing staff or endoscopy tech forget how to put them on correctly. And especially with clips, one has to be very careful because if your snare is touching it, it will dissipate the current from before it was.
So in putting a clip on, the standard clips you'll use a system called ABBA, which is advanced, back.
If I can add, you don't have this dummy, which I think is
Yeah.
size razor. You can't have that. Before you use any device, you must make sure that you and your tech understand what you're doing. If he's going to be releasing the clip, he needs to understand the mechanism because there are many clips available. And so you need to understand whether you've used it before or not. If you haven't, you can go to the YouTube, you can see how it's actually done. Every device has got a YouTube video, almost every device. Open that, spend some time, understand that with your tech. Okay? Make sure your tech understands, because if your tech doesn't understand, remember he's got the other end, and he doesn't do the job properly, you can't blame him. It's your fault. In our system, everything is your fault.
In every system.
Okay? They have much more organized, structured training for their techs as well. Unless your techs personally take interest, they would not know about these devices. So never use a device that you haven't used without actually going through the entire thing, understanding everything and then going for it.
So the clips that you'll be using a lot use a system called ABBA, which is advanced. So that means take the plastic sheath off so the actual clip comes out. Back, so that means that they actually open the actual clip. And then completely back to fire. But it stays attached to the actual clip. And then the next bit is A, which is advanced. So that means they open up. Now, what you're not aware of is that's a hook that holds the clip on, and it's been fired. When they advance, and you say, right, release, they open it. What it shoots forward is a 3 centimeter piece of steel, this length, with a hook on the end. And so as they open it like this, they shoot straight out. And that can actually go into the mucosa, perforate and hook on. And then you're trapped. The same thing for the ones that open and close. Now the ones that just open, as you open, that's forceps, and then close to fire, and it makes a clip sound, some people say release. That's still got the same device, which is a hook. And it still projects 3 centimeters out. So when I actually do a clip, I'll say slowly open, right? Advance it on, slowly close, great. So the ones where you have to use ABBA, they only open once, and then they're useless. The other type where it can open and close 5 times. Once they go on, you can see that they're correct. Then you fire it. Then it is, I want you to slowly release. But this is all discussed before you actually do the procedure. Slowly release, you let it go forward and then take it back. And then that doesn't allow it to skewer through the bowel wall. And it does, it will skewer through the bowel wall. I don't think there's anything else. What we want to go through. I think the big thing from that is that there's a lot of ways of actually taking off polyps. And I think in touching on a little bit more of an advanced polypectomy and just discussing it enables you to see what you should know, what you don't know, what you could know and what you should know. And the most important thing is to actually say, have I got the skills necessary to do what I've got? And that isn't, you shouldn't stand up and say, you know, this guy now will think I'm not very good if I don't do this. So what? If you haven't got the skill requisite at this moment in time, you haven't got it. Doesn't matter. Give it to somebody who can. People will respect you more for that than doing something stupid and dangerous.